In this video, I'll be discussing combined particulated juvenile cartilage allograft transplantation with autogenous bone graft for symptomatic osteochondral defects in the tibial plateau. A diagnostic arthroscopy is always performed using a standard 30-degree arthroscope through the anterolateral and anteromedial portals. This allows for a thorough assessment of any concomitant pathology and helps determine whether the use of de novo natural tissue allograft is appropriate. In this case, no other abnormalities are found in the knee. An unstable osteochondral defect measuring 16 by 16 millimeters is confirmed in the central aspect of the lateral tibial plateau. The lesion is probed and subsequently detached using a ring curette. It is then excised with a grasper, resulting in an osteochondral defect of the same dimensions. A number 4-5 shaver is used to perform a chondroplasty. Notably, there is significant bone loss at the base of the lesion, approximately 5 to 6 millimeters deep with sclerotic changes. These areas are carefully debrided with a handheld burr in preparation for further treatment. The base is left with adequate bleeding, which will enhance the potential for bone graft integration. At this point, the arthroscope is removed and attention is directed to the proximal tibia for bone graft harvesting. A 3 cm incision is made, centered above the pes anserinus, just medial and inferior to the tibial tubercle. The osteoauger bone graft harvesting system is used to collect approximately 8 cc's of autogenous bone graft, which is then mixed with 1 cc of demineralized bone matrix putty. The system is then uncoupled and the bone graft plunger is inserted into the distal end to push bone graft out of the proximal end. To address the tibial void, cancellous allograft chips are then inserted. Attention is turned back to the lateral tibial plateau. A 4 cm incision is made over the anterior knee, followed by a mini lateral arthrotomy. After partial excision of the infrapatellar fat pad, retractors are used to expose the lateral tibial plateau, and the defect is clearly visualized using arthroscopy. Bone graft is carefully delivered into the tibial plateau defect using the BioExpress graft delivery device. It is manually packed with a large freer elevator to ensure the graft is recessed to the level of the articular surface, extending up to the surrounding subchondral bone. Once the graft is properly positioned, fibrin glue is applied. Next, the de novo natural tissue allograft is delivered into the defect using a Craig biopsy cannula. A layer of fibrin glue is then applied, followed by the use of a freer elevator to evenly distribute the mixture across the defect, forming a uniform monolayer scaffold. It is critical to ensure that the graft is level with the surrounding tissue to prevent hypertrophy and minimize shear forces, which could affect the graft stability. Finally, passive range of motion is performed to confirm secure graft placement.